Thanks for holding this very important hearing. Madam Chair, data drives decision-making, as you know, and the integrity of these decisions lies in the integrity of the data. As you know, I'm from the great state of Florida, and Florida's COVID-19 story is one of success driven by reliable data and following the science. I've included a press release exposing myth versus fact regarding Florida's COVID-19 data, and I ask unanimous consent that this be entered into the record, Madam Chair. Madam Chair.
Did you hear it? So ordered.
Yeah, okay, thank you. Yeah, I didn't hear that. Thank you. Dr. Walker, Representative Blunt Rochester and I introduced the bipartisan collecting and analyzing resources integral necessary for guidance for Social Determinants Act, and it's HR 3894. And what it does is it provides regularly updated guidance to states to address social determinants of health under Medicaid and CHIP, building upon the success that some state Medicaid programs have already had since testing innovative delivery and payment models. Additionally, several members of this committee are championing the Social Determinants Accelerator Act, which is HR 2503, which would help states and communities devise strategy to better leverage existing programs and authorities to improve the health and well-being of those participating in Medicaid. So my question is, a couple questions. How might HHS do more to coordinate social determinant efforts, even without additional congressional authority? And then also, could you explain how HHS could use its leadership in Medicaid to more broadly catalyze efforts to better coordinate and measure the impact of resources and initiatives that address social determinants of health? And this is for Dr. Walker.
Thank you, Congressman, for the opportunity to address this question. It is absolutely critical to think about how to refine ongoing guidance to states around how to address social determinants of health. We know these impacts continue to evolve, and so even when I was State Secretary of Health and Social Services, it was extremely helpful to have this updated guidance provided. It informs waivers, it informs how you can think about state plan amendments, and as you mentioned, doesn't require necessarily additional authority, but gives clarity around where existing resources can be deployed and used most efficiently. And there are several models out there. So another strategy could be that models like that at the state level are incentivized through CMMI or other waiver authorities like North Carolina's. I expect we'll continue to learn from these models. So having evaluations and the data available can be incredibly useful, but also providing resources for technical assistance, updated guidance, and examples are tremendously beneficial. Thank you.
Thank you. And the next question is for Dr. Batra. Recently, I introduced HR 4074, the Addressing Social Determinants in Medicare Advantage Act, which increases flexibility for Medicare Advantage to offer supplemental benefits that would help address social determinants of health. Can you discuss how supplemental benefits have improved the lives of your members and how adding benefits that address social determinants of health in Medicare Advantage and broadening beyond just those with specific chronic conditions would mitigate social inequities and allow plans to assist even more members in need?
Absolutely. I had shared with the committee before, we really appreciated getting that flexibility. Post that flexibility, we have designed multiple newer benefits. I mentioned our benefit called Return to Home around medications, care coordination, and in-home caregiving. We also introduced benefits like respite care for our populations who have caregivers who could use that kind of a help. So we've used benefits for that. Beyond that, we extended our meal benefits to provide meals for our folks suffering from chronic conditions who perhaps need that a meal for their diabetes or need that meal for their end-stage renal disease that is appropriate for their condition, so they can have a better food lifestyle in order to improve on their chronic conditions. So those were a few high-level benefits that we introduced. We have seen, based on our either both the utilization adoption data as well as our outcomes data, when we look at our utilization from ER visits or admissions or improvement in diabetes control and improvement because of those kind of benefits. We continue looking at more benefits, and as I had shared with the committee, would love to have benefits based on your social needs versus just based on your medical conditions. Right now, we do have the flexibility, but they're still tied to chronic conditions like diabetes or heart disease or cardiovascular disease or chronic kidney disease. But we know, as I shared, we have about 20% of our membership that has at one time or the other shared with us they have food insecurity. We would be able to do more if we were able to address needs of larger population, not limiting ourselves just to chronic conditions.
Thank you. And I just want, Madam Chair, this particular bill, H.R. 4074, I filed it due to timing alone, but I welcome bipartisan support, both in this committee, Ways and Means, and any members that want to. I think this is a very important issue for the constituents. Thank you, and I yield back. Thank you for the extra time, Madam Chair.